Welcome to the Complete Respiratory Blueprint, a high-yield systems integration covering anatomy, embryology, histology, biochemistry, and physiology in one unified framework. The respiratory system is built on 5 interlocking foundations. Anatomically, the right lung has 3 lobes and 10 bronchopulmonary segments, while the left lung has 2 lobes and 8 to 9 segments, with the trachea supported by C-shaped cartilage and the bronchial tree branching across 23 generations. Embryologically, the lung arises as a foregut endoderm derivative, with lung buds appearing in the 4th week and progressing through 5 distinct developmental stages. Histologically, the airway is lined by pseudostratified ciliated columnar respiratory epithelium with mucus-producing goblet cells, while the alveoli contain type 1 squamous cells for gas exchange, type 2 cuboidal cells for surfactant production, and alveolar macrophages for defense. Biochemically, surfactant, composed of dipalmitoyl phosphatidylcholine and surfactant proteins A, B, C, and D, reduces surface tension according to the law of Laplace. And physiologically, ventilation and perfusion, governed by Fick's law of diffusion, oxygen and carbon dioxide transport, and central control of breathing complete the picture. This video walks through every one of these domains systematically and mechanistically. The respiratory system can be understood through 5 interconnected lenses, each building on the last. Form refers to anatomy, the macroscopic scaffolding of lungs, airways, and chest wall. Foundation refers to embryology, the architectural origins explaining how this scaffolding came to exist in the first place, from early lung bud formation through progressive maturation. Fabric refers to histology, the structural materials, the specific cell types and tissue arrangements that make up the airway wall and the alveolus. Fuel refers to biochemistry, the molecular mechanisms, including surfactant synthesis and the biochemical pathways underlying gas transport. And function refers to physiology, the machine in motion, encompassing pressure-volume relationships, flow-volume curves, and ventilation-perfusion matching. The central clinical directive uniting all 5 domains is this: true mastery of medical board examinations requires viewing a single patient vignette through all 5 domains simultaneously. Rote memorization of isolated facts within any one domain fails under exam pressure, while mechanistic integration across all 5 domains succeeds, allowing you to reconstruct any clinical finding from first principles, rather than relying on disconnected recall. The upper respiratory tract follows a logical anatomical and physiological sequence, with each region's epithelium precisely matched to its function. The nasal vestibule is lined by stratified squamous epithelium, providing mechanical protection against abrasion from inspired air and particles. The nasal conchae are lined by respiratory epithelium, specifically optimized for warming and humidifying inspired air before it reaches the lower airways. The pharynx is anatomically significant due to its close proximity to the pharyngeal tonsil, or adenoid, and the eustachian tube, explaining why adenoid hypertrophy in children predisposes to otitis media. The larynx serves the dual function of airway protection and phonation. 2 board favorite facts deserve special attention here. First, the cricoid cartilage is the only complete cartilaginous ring in the entire airway, making it the narrowest fixed point in the pediatric airway and the essential anatomical landmark for emergency cricothyroidotomy. Second, the maxillary sinus ostium is located high on its medial wall, meaning gravity-dependent drainage fails when the patient is upright and worsens further when supine, directly explaining the clinical pattern of sinusitis symptoms. The trachea bifurcates at the carina, located at the level of vertebrae T4 to T5, corresponding clinically to the sternal angle, an essential surface landmark. This bifurcation point carries major clinical significance for foreign body aspiration, because the right main bronchus is wider, shorter, and more vertically oriented than the left. Aspirated objects, such as a coin, classically lodge here rather than on the left side. At the hilum of each lung, The anatomical relationship of structures follows a consistent pattern from anterior to posterior, remembered by the mnemonic VAB, vein, artery, bronchus. An important asymmetry exists between the two sides. The right pulmonary artery passes anterior to the right main bronchus, while the left pulmonary artery arches directly over the left main bronchus. Beyond pure anatomy, this region also explains an important clinical correlate regarding pleural pain referral. The central diaphragm is innervated by the phrenic nerve, arising from cervical roots C3, C4, and C5, which means diaphragmatic pleuritis characteristically refers pain to the tip of the shoulder rather than to the chest itself, a classic example of anatomy directly explaining an otherwise puzzling clinical symptom. Lung development unfolds across 5 sequential, overlapping stages, and this viability timeline is one of the most heavily tested concepts in respiratory embryology. The embryonic stage, spanning weeks 4 through 7, establishes the lung bud, trachea, and the primary and secondary bronchial buds, all arising from foregut endoderm. The pseudoglandular stage, spanning weeks 6 through 16, produces a lung that resembles an exocrine gland histologically, but critically, no respiratory bronchioles exist yet, making respiration completely impossible during this stage. The canalicular stage, spanning weeks 16 through 26, introduces primitive alveolar ducts, and crucially, week 24 marks the limit of extrauterine viability, since this is the earliest point at which minimal gas exchange becomes theoretically possible. The saccular stage, spanning weeks 26 through 36, sees terminal sacs proliferate, while type 2 pneumocytes begin meaningful surfactant production. Finally, the alveolar stage, spanning week 36 through approximately 8 years of age, dramatically increases surface area through septation, expanding the alveolar count from roughly 50 million at birth to over 300 million in the mature lung. An essential clinical correlate here is tracheoesophageal fistula, where the most common variant, type C, accounts for 85% of cases, combining esophageal atresia with a distal fistula, classically presenting with polyhydramnios in utero and an inability to pass a nasogastric tube after birth. As the airway progresses from the trachea down to the alveoli, both its epithelial lining and its supportive tissue undergo a predictable, gradual transition that explains a remarkable amount of respiratory pathology. The epithelium transitions from pseudostratified ciliated columnar in the trachea and bronchi to simple columnar in smaller bronchi to simple cuboidal containing Clara cells in the bronchioles, and finally to simple squamous in the alveoli, optimized purely for gas diffusion. Simultaneously, the supportive tissue composition shifts dramatically. Hyaline cartilage is abundant in the trachea, but progressively disappears by the level of the bronchioles, while smooth muscle becomes increasingly dominant precisely where cartilage disappears, peaking in the bronchioles, before also diminishing toward the alveoli. This explains why bronchiolar diseases such as asthma involve smooth muscle bronchospasm rather than cartilage pathology. One critical board favorite exception breaks this otherwise smooth pattern. The true vocal cords retain stratified squamous epithelium rather than the expected respiratory epithelium, specifically to withstand the mechanical trauma of repeated vibration during phonation. And this is precisely why the vocal cords are the classic site of origin for squamous cell carcinoma of the larynx. The blood-air barrier represents the final, critical interface where gas exchange actually occurs, and its structure is a direct, elegant application of Fick's law of diffusion. Type 1 pneumocytes account for 95% of the alveolar surface area, despite representing only about 40% of total alveolar cell count. Thin, flattened cells perfectly optimized for diffusion, but critically, they cannot regenerate once damaged. Type 2 pneumocytes, by contrast, make up roughly 60% of alveolar cell count, are responsible for surfactant production, and serve as the essential progenitor stem cells that repopulate the alveolar surface after injury, since type 1 cells cannot replace themselves. The blood-air barrier itself measures only 0.2 to 0.5 micrometers in thickness, an extraordinarily thin distance that directly maximizes diffusion efficiency. Fick's law formalizes this relationship precisely. The rate of gas diffusion equals surface area divided by thickness, multiplied by the diffusion coefficient and the partial pressure gradient between the two sides of the membrane. This single equation explains why diseases that increase membrane thickness, such as pulmonary fibrosis, or reduce surface area, such as emphysema, both impair gas exchange through entirely different structural mechanisms, converging on the same physiological consequence. Surfactant is the molecular key to preventing alveolar collapse, and understanding both its composition and its governing physical law is essential. The primary phospholipid component is dipalmitoyl phosphatidylcholine, also called lecithin, making up the bulk of surfactant's lipid content. 4 surfactant proteins complete the picture. SPA and SPD are hydrophilic proteins, primarily involved in innate immune defense within the alveolus, while SPB and SPC are hydrophobic proteins, essential for proper surfactant film spreading and stability at the air-liquid interface. The governing physical principle is the law of Laplace, expressed as pressure equals 2 times tension divided by radius. This explains a counterintuitive but critically important point. Surfactant must lower surface tension more significantly in smaller alveoli, specifically because smaller radius alveoli would otherwise generate dangerously higher collapsing pressure according to this equation, and without proportionally greater tension reduction, these smaller alveoli would collapse into larger ones at end expiration. The essential clinical correlate is fetal lung maturity testing. An amniotic fluid lecithin to sphingomyelin ratio greater than 2:1 indicates low risk of neonatal respiratory distress syndrome, and antenatal corticosteroids work specifically by accelerating type 2 pneumocyte maturation ahead of an anticipated preterm delivery. Oxygen transport by hemoglobin follows a sigmoidal dissociation curve, and 2 reciprocal effects explain how oxygen is released precisely where it's needed and picked up precisely where it's available. At the tissues, the Bohr effect dominates. Decreased pH and increased carbon dioxide both lower hemoglobin's affinity for oxygen, forcing oxygen to unload specifically into metabolically active tissue that has generated this local acidity and carbon dioxide in the first place. At the lungs, the Haldane effect operates in the opposite direction. Oxygenation of hemoglobin lowers its affinity for carbon dioxide and hydrogen ions, forcing carbon dioxide to offload into the alveoli for exhalation. The factors causing a rightward shift of the dissociation curve, reducing hemoglobin's oxygen affinity, are conveniently remembered through the mnemonic cadet faces right. Carbon dioxide, acid, 2,3-bisphosphoglycerate, exercise, and temperature. A particularly high-yield board fact concerns fetal hemoglobin. Its dissociation curve is shifted left compared to adult hemoglobin, specifically due to lower binding affinity for 2,3-bisphosphoglycerate. And this leftward shift ensures a one-way oxygen gradient, flowing from mother to fetus across the placenta. Blood pH is governed by the Henderson-Hasselbalch equation, where pH equals 6.1 plus the logarithm of bicarbonate divided by 0.03 times the partial pressure of carbon dioxide. This single equation can be visualized as a balance scale, with 2 arms operating on dramatically different timescales. Respiratory control adjusts the denominator of this equation, the partial pressure of carbon dioxide, through changes in ventilation, and this adjustment occurs rapidly, within minutes to hours. Metabolic control adjusts the numerator, bicarbonate concentration, through renal excretion or reabsorption, but this adjustment takes considerably longer, on the order of days. This timing asymmetry is precisely what allows clinicians to distinguish acute from chronic acid-base disturbances using a single blood gas measurement. Beyond acid-base balance itself, carbon dioxide transport in blood occurs through 3 distinct mechanisms. 70% travels as bicarbonate, 10% binds directly to hemoglobin as carbaminohemoglobin, and 10% remains simply dissolved in plasma. The chloride shift, also called the hamburger phenomenon, describes the essential ion exchange maintaining electrical neutrality during this process. Bicarbonate exits the red blood cell, while chloride simultaneously enters to take its place. Lung volumes are built from 4 fundamental components stacked together. Tidal volume, the roughly 500 milliliters moved during normal quiet breathing, sits between inspiratory reserve volume above it and expiratory reserve volume below it, with residual volume, the unexhalable air remaining after maximal expiration, at the very base. Vital capacity combines tidal volume with both reserve volumes, while functional residual capacity combines expiratory reserve volume with residual volume, and total lung capacity combines absolutely everything together. A critical board gold fact, residual volume, and therefore both functional residual capacity and total lung capacity, cannot be measured by spirometry alone, since spirometry cannot detect air that is never exhaled. This requires helium dilution or body plethysmography instead. This distinction directly explains the obstructive versus restrictive comparison. Obstructive disease, such as asthma or COPD, shows increased residual volume, functional residual capacity, and total lung capacity from air trapping, a reduced FEV1 to FVC ratio below 0.7, and high compliance, particularly in emphysema. Restrictive disease, such as pulmonary fibrosis, shows decreased total lung capacity, a preserved or increased FEV1 to FVC ratio, and low compliance from stiff, non-distensible lungs. Ventilation and perfusion are not uniformly matched throughout the lung, and visualizing this relationship as a spectrum across the entire organ resolves an enormous number of clinical questions. At the apex of the lung, the ventilation to perfusion ratio runs high, approximately 3, meaning ventilation substantially exceeds perfusion at this location, approaching the behavior of pure dead space. And this is precisely why reactivation tuberculosis favors the apex, since this relatively oxygen-rich, blood-poor environment suits this obligate aerobic organism. At the base of the lung, the ratio runs low, approximately 0.6, meaning perfusion substantially exceeds ventilation, approaching the behavior of pure shunt. And this is why aspirated fluid in aspiration pneumonia characteristically pools here under gravity. At the extreme ends of this spectrum, a pure shunt occurs when the ratio equals 0, as in complete atelectasis. And critically, this state does not improve with 100% supplemental oxygen, since blood simply never contacts any ventilated alveolus at all. A pure dead space occurs when the ratio approaches infinity, as in pulmonary embolism. The essential clinical correlate is hypoxic pulmonary vasoconstriction. Localized alveolar hypoxia triggers local vasoconstriction, diverting blood toward healthier alveoli. But when hypoxia becomes global, as in COPD or high altitude, this same mechanism instead causes diffuse pulmonary hypertension and eventual cor pulmonale. Breathing is controlled by 2 anatomically and functionally distinct chemoreceptor systems, and understanding their separate triggers explains some of the most clinically important physiology in respiratory medicine. Central chemoreceptors are located in the medulla, bathed directly in cerebrospinal fluid, and they are exquisitely sensitive specifically to CSF pH. The underlying mechanism depends on a key biochemical fact. Hydrogen ions and bicarbonate cannot cross the blood-brain barrier, but carbon dioxide crosses readily, lowering CSF pH once inside and directly driving the central respiratory rhythm through this indirect pathway. Peripheral chemoreceptors, located in the carotid and aortic bodies, respond directly to PaCO2 and pH, but their response to PaO2 is fundamentally different. They become significantly activated only once PaO2 falls below approximately 60 millimeters of mercury, rather than responding proportionally across the entire normal range. The essential clinical correlate, frequently tested and clinically vital, is the COPD hypoxic drive phenomenon. Chronic carbon dioxide retention desensitizes the central chemoreceptors over time, causing the patient's respiratory drive to become dangerously dependent on the peripheral hypoxic drive instead, which is precisely why high-flow oxygen must be administered with caution and careful titration in these patients, since removing hypoxia can paradoxically blunt their remaining respiratory drive. 3 distinct clinical mechanisms illustrate how structural, transport, and diffusion principles converge into recognizable disease. Congenital diaphragmatic hernia results from failure of the pleuroperitoneal membrane to close, classically the Boctelic type, allowing abdominal viscera to herniate upward into the thoracic cavity and causing pulmonary hypoplasia. This produces the classic neonatal triad: a scaphoid abdomen, bowel sounds audible within the chest, and significant respiratory distress. Cystic fibrosis results from defective chloride transport at the cellular level, creating thick, dehydrated mucus that leads to mucociliary clearance failure and chronic colonization by Pseudomonas aeruginosa, predisposing to bronchiectasis. Diffusion limitation illustrates an elegant physiological distinction. Carbon monoxide is inherently diffusion limited since it binds hemoglobin so avidly that plasma levels never approach equilibrium, making it the ideal test gas for measuring diffusing capacity. Oxygen, by contrast, is normally perfusion limited under resting conditions, reaching alveolar partial pressure well before the red blood cell exits the capillary. But oxygen transfer can become diffusion limited instead in pulmonary fibrosis or during strenuous exercise, when capillary transit time becomes too short for complete equilibration across a thickened or rapidly traversed membrane. We can now bring every domain together into a single master clinical vignette that demonstrates true integrated mastery. A neonate born at 28 weeks gestation presents with severe tachypnea, grunting, and cyanosis, and the chest X-ray shows diffuse ground glass opacities. From an embryological foundation, this infant was born in the early saccular stage, meaning terminal sacs are present, but there has been insufficient time for full maturation. From a histological perspective, type 2 pneumocytes are structurally immature and insufficient in number to secrete adequate lamellar bodies. From a biochemical perspective, this translates into a severe lack of dipalmitophosphatidyl-choline, with an L to S ratio below 1.5, confirming inadequate surfactant production. From a physiological perspective, the resulting high surface tension drastically decreases lung compliance, causing alveoli to collapse at end expiration and creating a massive ventilation perfusion shunt. And anatomically, the diaphragm is forced to work against this immense elastic recoil, producing the visible chest wall retractions and progressive respiratory exhaustion observed clinically. This single vignette demonstrates the core principle of the entire respiratory blueprint. True mastery of the integrated respiratory system leaves no domain isolated.